Priti, you're muted. You can unmute yourself.
Yeah. Am I audible now?
Yes.
Yeah. Is my screen visible to all?
Yes.
Yeah. So, good evening all. Before I start, I would like to thank all the mentors at Diagnopool and my dear friend Dr. Divya for the kind introduction and this wonderful opportunity. Thank you, Divya. With this, I will start my topic, that is general principles of antimicrobial susceptibility testing. So here I will be discussing more about antibiotics. So I have changed the topic to antibiotic susceptibility testing, which I will be hereafter referring as AST. So first and foremost question, why this topic? So first and foremost, being a microbiologist, I feel it's my responsibility to create awareness whenever given a chance to contribute my few cents towards the uphill battle against AMR. And I hope by end of this talk, the AST report is not just considered as a mere piece of paper, but as a valuable information tool to get best possible outcomes for our patients, because they are the center of our importance. Without AST reports, it will be like searching the Sanjeevani booty, here the right antibiotic for our patients without no clue at all. Secondly, the alarming rise in AMR, which is not only a local or a national issue, but a global issue, which is even more fast-tracked due to the COVID-19 pandemic. So the silent pandemic of AMR is no more silent. These AST reports form the backbone of any infectious disease management for optimal patient outcome. And with help of these quality reports, we can equip our clinicians with quality reports and make them more confident while prescribing the antibiotics. The AST report helps generate antibiograms, which in turn guides for empiric therapy, resistance mechanism detection, outbreak detection, framing the hospital antibiotic policy, infection control program, observe trends of interventional methods like hand hygiene, cohort nursing, prescription auditing, and thus serves as a blueprint for the antimicrobial stewardship program. Last but not the least, to stop the overprescribing or misuse of antibiotics. So what are the major reasons for this overprescribing? Positive cultures for every site and from every place is treated. This could be due to the fear, the pressure from the patient team, overzealous attitude of the treating physician, wrongly interpreted lab reports, and lack of knowledge. Failure to differentiate between the colonizers and contaminants from true pathogens. For example, treating candida in sputum. Increasing rates of litigations, non-updated rulers who still believe antibiotic is the elixir which cures everything, be it fungal, be it viral, be it parasitic. Everything is cured by antibiotics. Inadequate support from diagnostics, diagnostic delays, errors in reporting, QC errors, interpretation errors, lack of trained staff, and lack of proper resources. Few other reasons are the medical representatives of pharmaceutical companies act as a source of drug update in most of the primary and secondary care centers. Use of broad spectrum drugs for all. Although initial broad spectrum cover is life-saving in critical cases, but should be with appropriate antibiotics. And what is the solution for this? Please follow your hospital antibiotic policy to start the empirical treatment. Failure to de-escalate or failure to understand antimicrobial spectrum. For example, giving GPC drugs for GNBs or GNB drugs for GPCs or vice versa. Failure to achieve a syndromic diagnosis, even if it achieved, failure to mention that while ordering a test. An umbrella approach is followed and a polypharmacy is started, including the antibiotics. Coming to broad spectrums, are not truly broad spectrum. Some of the newbies in the BLBLI market, for example, Cefta-IV. So these are primarily and predominantly they act against organisms inoculating KPC, INT, and BIM. But bulk of our Indian pathogens are NDM and OXA. So we need to be aware of our local pathogens. Misuse, overuse, and misinterpretation of biomarkers is one more reason for overprescribing, like procalcitonin, CRP, ESR. Belief that some antimicrobials cover everything. Few drugs considered as super drugs, but in reality they are not. A very good example is of colistin. Let me share you the spectrum of action of polymyxins. So colistin belongs to the group of antibiotics, that is polymyxins. So colistin is susceptible in these cases. That is gram-negative bacilli, but it is resistant in all gram-positive organisms, few gram-negative foci, and also few gram-negative bacilli. So you need to know the spectrum of antibiotic of the bacteria. So remember, colistin is not a super missile. So what I shall elaborate going forward, certain expert rules, case-based AST reports are also known as the customized or tailor-made reports, especially in case of critical patients. So there it is one size does not fit all. You have to alter according to the PKPD of the drugs, also according to the status of the patient. Then selective and cascade reporting. What not to do, that is what errors, mistakes or blunders commonly done in AST report interpretation, and what drugs not to report against certain bugs and certain samples. So knowing how to interpret the report and little fine tuning with CLSI and UCAS will give you a very refined AST report. Coming to interpreting a culture sensitivity report, it is a very big task, a drawing task. So what it tells you, it identifies the bacteria or fungus if it is present most of the time. So the primary sample, your sample is very, very important. Next is the susceptibility results based on your lab data. What it does not tell you, it does not identify between infection or colonization or contamination. So coming to what is AST, AST stands for Antimicrobial Susceptibility Test. It's the overall susceptibility profile of a microbe, that is a bacterium, to a battery of antimicrobial agents. It's an in vitro method which is done under controlled lab conditions to check in vivo inside the host antimicrobial response, that is human versus lab. So basically it is a very complex process and guided by the clinical microbiologists that will assist the healthcare professionals in the management of their patients. So how the process is complex, it is very nicely depicted by Burke. Susceptibility testing is an in vitro phenomenon and does not necessarily reflect or predict in vivo efficacy. Susceptibility testing is subject to great variability depending on pathogen tested, media used, conditions of incubation, and method of accessing bacterial growth. Coming to different AST methodologies, we have phenotypic methods, some biochemical mechanisms, and detection of resistant genes by the genotypic methods. So coming to the phenotypic methods, agar disk diffusion is one of them. Here it is done by the PritiBala disk diffusion method. And these are the antibiotic discs which are impregnated on a growth plate, and whatever the zone of inhibition is formed, that is measured, and it is compared to the standard guidelines, and based on that the reports are interpreted. The second type is the determination of MIC. MIC is the lowest concentration of an antimicrobial that results in inhibition of visible growth of a microorganism. So minimum inhibitory concentration is inversely related to zone diameter. Larger the zone diameter, lower will be the MICs. Various methods of MIC determination are broth macro dilution, broth micro dilution, agar dilution MIC. Mind it, this is different from the agar disk diffusion method. Then comes the gradient diffusion or the E-test. Various automations are used nowadays for MIC testing. The most commonly used is Vitek2 by bioMero. Others are the Siemens Microscan Walkaway AST system, BD Phoenix AST systems. The genotypic methods or molecular methods, they are gaining ground nowadays. So few of them, the commonly heard names are the expert Carla, BioFire, or the whole genome sequencing is also being tried to detect the various genes. So the most important thing of molecular methods is the TAT is very low in such cases. Coming to Amitabh Bachchan of the topic, the attributes of an AST report. So what an ideal AST report should look like. So these are few parameters that should be present on your AST report. Unique identifiers, patient identifiers, then patient demographics, age and sex, lab identification, referring doctor name and contact details to convey information in case of any critical alert or to discuss about the case, time and date of the sample collection, time of lab receival and reporting. Sample details, brief clinical details, which is 99% of the times it is missing. The sample site. So why sample site is important? For example, in a pus swab, if we don't know the site because pathogens are site specific. So mentioning the site or a brief clinical history is very, very important on the part of clinicians. Then comes the centrifuge or uncentrifuged samples or any other process done to the sample. So basically this is useful in urine samples. So in microbiology we use the uncentrifuged samples. The biological reference interval, colony count of row significance. Again, in case of urine sample, colony count is very, very important. In bronchoalveolar lavage samples, then comes the interpretation, whether in the form of MIC or zone diameter you can give, and interpretation is given as SRI or SDD. And the final is clinical footnotes. So this is the part where actually the microbiologist is talking to the clinician. So this part is very, very important. Now I'll be discussing few of the existing reporting practices which are leading to AMR. Not every lab will be having all these practices. So it's just a few examples, and going forward I'll be discussing what are the solutions. So that will in turn help us to improve our AST reporting. So reporting plus or minus. So this is not given in any guidelines. Reporting without referring to recent updated guidelines. Competition among different labs to report the maximum number of antibiotics. So more commonly seen in standalone labs. So we give 40 antibiotics for particular bug. We give 50 antibiotics. So please don't have blind faith on all those reports. Go by the spectrum, go by the guidelines. Reports authorized by non-clinical microbiologists without interpretation. Missing clinical details by the prescribers and no interpretive footnotes by the reporting microbiologists. So both are partners in crime, both the diagnosticians and the prescribers, which is leading to AMR. Lack of effective communication between the diagnosticians and prescribers. Nobody wants to communicate. Only the report goes into the patient file. Asking susceptibility for each and everything. Few other reporting blunders, when a machine or Vitek report is directly copy-pasted without proper filtering and interpretation, ignoring the intrinsic resistance, no selective reporting or cascade reporting, reporting unusual phenotypes without rechecking if required to be sent to reference center, reporting wrong drug bug combinations or wrong drug for specific site, lack of quality checks at all levels, that is pre-analytical, analytical and post-analytical. So here most important the post-analytical interpretation part, lack of warning comments for alert organisms. So what you should do with all such reports? So there is a very good saying in quality, garbage in is garbage out. So if you put all the garbage in, all the wrong things at pre-analytical, analytical, so your results will be garbage. So trash all such AST reports, because first rule when we become a doctor or a healthcare worker is do no harm. Coming to the first point, reporting as plus or minus or so on. So how it should be ideally reported, the solution is CLSI or UCAST. it asks us to interpret as S, I, and R. So what does S stand for? S is susceptible, indicates the antimicrobial agent is clinically effective when used in standard therapeutic dose. I is intermediate, indicates that antimicrobial agent may still be clinically effective when used with increased dose or frequency if the patient vital parameters permit. However, established clinical trials are not available, and it may also indicate therapeutic efficacy in physiologically concentrated sites. Coming to SDD, that is susceptible dose dependent, it is similar to intermediate, only differences here the clinical trials have confirmed that the antimicrobial agent can be clinically effective when used with increased dose or frequency if the patient vital parameters permit. Next is R, that is resistant, indicates clinically ineffective when used in standard or increased therapeutic dose. Next, reporting without referring to recent updated guidelines. So what is the solution? Be updated, check that your lab uses standard guidelines, check that the latest updated version is being used. So for the CLSI M100 32nd edition is going on currently, and UCAS 2022 edition. So these are the holy books. So when you don't get any answers, we go back to these holy books. So we call them as the holy books in microbiology. And few UCAS warnings are updated from time to time. So that will help you select between different testing products and procedures, because they will issue a warning concerning antimicrobial susceptibility testing products or procedures. So check if you are not using those products. Coming to the next thing, the lack of effective communication between diagnosticians and difference, and to determine significance of result requires knowledge of patient's clinical status. The report should always encourage communication. Missing clinical details by the prescribers and no interpretive footnotes by the reporting microbiologist. The solution is comments and footnotes should be added to the AST reports. So adding a comment, it helps in 3 ways. Adding a comment can influence prescribing. For example, a third generation cephalosporins are not recommended for treating serious infections caused by Enterobacter. So basically, in these organisms, antibiotic combinations, there is risk of developing resistance during prolonged therapy. And isolates that are initially susceptible may become resistant within 3 to 4 days after initiation of therapy. Therefore, if patient is clinically not improving, repeat culture antimicrobial susceptibility test is necessary after 3 to 4 days of initiation of therapy. So these are the comments that should go with your report if you are isolating Enterobacter. Then comments which can influence practice. Example, ID consult recommended for Staphylococcus aureus bacteremia because it is a havoc causing organism. So you should alert your treating physician. The renal adjustments, any susceptibility for vancomycin, colistin or amikacin, as colistin, amikacin is nephrotoxic, so kindly adjust the maintenance dose. So these are few of the interpretive footnotes which can influence practice. Thirdly, the infection control related advice. For example, if you are isolating MDRO or MRSA, so you should put those relevant footnotes. Microbiology lab may not perform an AST for a particular bug-drug combination, so please stop asking AST for each and everything. So AST may not be performed on bacteria suspected of being contaminants or usual flora. Example, 2 blood cultures are performed, and one of the 2 cultures reveals growth of Staph epidermidis, that is cons. So AST isn't performed as the isolate is a suspected contaminant. Then second example, AST may not be performed if susceptibility or resistance can be predicted based on the organism identification alone. That is, no resistance yet identified or intrinsic resistance. For example, AST isn't performed for ceftriaxone and Pseudomonas aeruginosa because Pseudomonas aeruginosa is intrinsically resistant to ceftriaxone. I'll be coming in further slides what is intrinsic resistance. AST may not be performed if susceptibility or resistance can be predicted based on the results of other drugs tested. So we have few surrogate markers. Example, An isolate that is susceptible to ceftazidime can be inferred to be susceptible to ceftaroline. Then fourth is a particular bug-drug combination may not be tested by the lab. Example, lab often uses automated instruments to perform routine AST, so certain drugs may not be on the chosen panel and thus are not routinely tested. Example, a recently approved drug may not be there on the list. A particular bug-drug combination may not have interpretive breakpoints. So, for example, there are no CLSA or FDA breakpoints for acylate. So AST results reporting may be modified for few reasons. The performance of a secondary phenotypic test, for example, a D-zone test on Staph aureus isolate is positive. We call it as inducible resistance to clindamycin. So, example, the lab may change the interpretation of cephalosporin from susceptible to resistant. So, in that case, if the D-zone is positive, the lab might give clindamycin as resistant directly. The performance of a secondary molecular test. Example, a MAT is performed and found to be positive for McA in Staph aureus. So, thus a Staph aureus isolate is reported as resistant to vancomycin even though it was susceptible based on the MIC results. So, these are few examples where the AST reports are modified by the lab. The lab or an automated instrument used by the lab follows expert rules. Example, a lab changes an interpretation from susceptible to resistant if it is not there in the software of that particular, if that phenotype is not present in the software of that particular automated instrument. So in that cases, the lab can modify the AST results. Coming to intrinsic resistance. So ignoring intrinsic resistance is a bigger blunder. So what is this intrinsic resistance? Inherent, innate, not acquired resistance, which is reflected in wild-type antimicrobial patterns of all representatives of a species. So intrinsic resistance is so common that susceptibility testing is unnecessary. So this is given very nicely in the CLSA M100 Appendix B. So you should always have the copy of the Appendix B in your lab. So to see the intrinsic resistance. And this intrinsic resistance is also species specific. For example, you can see in Proteus, it is different for different species of Proteus. That's why the correct identification of the organism up to species level is very, very important. These are few footnotes for intrinsic resistance to alert the clinicians or the treating physicians that what are the particular drugs which is intrinsically resistant for this bug. So please do not use this even though it is come as susceptible in your AST report. Coming to selective reporting, which is a primer for antimicrobial antibiotic stewardship programs. So understanding selective reporting. Selective testing means AST results for a particular bug-drug combination are not tested at all. Selective reporting is AST results for a particular bug-drug combination are obtained, but results are not reported in the electronic health record or not given in the patient record. Cascade reporting. So AST results for a particular bug-drug combination are obtained, but results are not reported for broader spectrum agents unless the bug is resistant to the narrow spectrum agents. So basically, cascade reporting is a subset of selective reporting. So why do we do selective reporting? A particular bug-drug combination may be inappropriate for a given site of infection. Example, daptomycin AST results are not reported on isolates from a respiratory source. A drug is not on the facility formulary. For example, a lab AST panel for Enterobacter AST contains 3 carbapenems, but only 2 carbapenems are on the facility formulary. So the AST results for the non-formulary drug are not reported. Then a particular testing method may have a drug-bug combination limitation. For example, a penicillin disc susceptibility test on Staph aureus isolate can be reported if the result is resistant, but a confirmatory test is required before reporting a susceptible result. Then a drug may be inappropriate for a particular patient population. Example, AST result for certain drug classes such as very commonly fluoroquinolones or tetracyclines, they are not reported for children. Hence, the information about the age and age of the patient is very, very important, as we saw in the attributes of AST report. Again, coming to facilities may perform selective reporting based on medical literature suggesting suboptimal outcomes with particular drugs in the treatment of specific resistance phenotypes of serious infections. For example, some labs may not report PIP as results for ceftriaxone resistant E. coli isolates from blood culture. Cascade reporting may be performed in some situations. For example, carbapenem AST results are not reported for E. coli if the isolate is susceptible to ceftriaxone. So we saw the broader agents are not reported if the narrow spectrum, if the bug is sensitive to narrower spectrum antibiotics. So that is cascade reporting. So coming to factors which influence the quality of our AST report. So these are all common factors: pre-analytical right specimen, right collection, right labeling, right quantity, right transport and storage, analytical, right lab professionals. So well-trained clinical microbiologists, reagents, equipment, selection of tests, various SOPs, in post-analytical recording, interpretation. So interpretation forms the major gist of your post-analytical and AST reporting. Turnaround time and report going to a right user. So again, put alert organism reports, put it in your footnotes, identify possible agreed alert organisms, so like MRSA, VRE, MDROs, ESBS and Clostridium difficile. Now coming to how to zero down on the panels. So clinical, first of all, check the clinical significance of your sample. If it is swab, ET aspirate, sputum, so look out for the colony counts, see for the gram stain. So first and foremost is check if it is worth processing. Next comes, if it is worth processing, go ahead. Next is what bug it is. So accurate identification of the bug is the most critical step. And I already told you till the species level. So that is very, very important because the intrinsic resistance differs even among different species of same genus. Then what is your sample? Sample type, host. So like we saw, tetracycline fluoroquinolones cannot be given in children. Then the location of the patient. So based on that,
his presentation was not of the screen.
Hello.
I can present once more. I think the presentation is not visible.
Okay, yeah. Is it visible, sir?
I was not able to see. I can just see the side view.
No, we can see, sir.
All right, then, sure.
Okay, the alert organism reports, that slide is there. Yes, yeah. So this is how we zero down on the panels. Then route of administration, and once the identification is final, rule out drugs which are intrinsically resistant, as I already told you. Check for the appendix B of CLSI M100 of recent edition. Then right panels, right methodology, and this leads to right reporting. So next is the most sought for query. So how to choose between different drugs if both are sensitive, which will be better for the patient. The solution, the antibiotic which is highest breakpoint to MIC quotient, that is BMQ, will have more chances of giving better outcome. So BMQ is nothing but the susceptible breakpoint upon the MIC. So what is this breakpoint? So breakpoint is the highest plasma concentration of the drug that can safely be achieved in the patient and defines whether an organism is susceptible or resistant to the drug. This number is derived from in vitro susceptibility testing used by clinical microbiologists to tell clinicians whether the antibiotics will work, could work, or will fail in vivo against a given organism. So what is the difference between a breakpoint and clinical breakpoint? The clinical breakpoint values are determined by specific criteria described by UCAS, and criteria includes the dose, target organisms and its resistant mechanisms, MICs, clinical indications, PK/PD properties, toxicity and desired clinical outcome. So coming back again to BMQ. We have various susceptible breakpoints. Those are given by U+. So for example, these are the breakpoints which are given by U+. So while calculating, if you, for example, in a patient in E. coli is isolated from urine culture, which is in significant count, the organism is susceptible to both norfloxacin and nitrofurantoin with following MIC values. So which drug to choose? So here BMQ comes for your rescue. So BMQ for norfloxacin. So again susceptible breakpoint for norfloxacin. So here we can see for norflox it is 4. The susceptible breakpoint for norflox is 4. And for nitrofurantoin it is 32. So BMQ for norflox will be susceptible breakpoint upon your MIC. So MIC was 4 and for this nitrofurantoin it was 8. So here the BMQ is 1 and BMQ for nitrofurantoin is 4. So which is largest? The nitrofurantoin. So that will be the preferred choice if both drugs are sensitive. But this is just a rough estimate. So you have to consider also the PK/PD parameters, especially in critically ill patients. Few more points to remember. CLSI classes are given A, B, C, and it is not equivalent to first line, second line, and so on, which is actually wrongly interpreted by many people. That classes A, B, C are equivalent to first line, second line. No. So first line and second line agents to be decided based on your local antibiogram, or you can take help of any national body like NCDC or ICMR has published recent guidelines. Or if you want to form your antibiotic panels, you can refer to few SOPs which are given by NARS-NET. So these are easily downloadable. So to start with, you can check these panels. Include all relevant drugs in your panel when you are putting up AST, but report selectively. So I have already mentioned the importance of selective reporting. Then record all in raw data, either in an Excel sheet or a software, or HomeNet. HomeNet is the best. Then follow current consensus recommendations for breakpoints availability like FDA, CLSI, IDSA, WHO, CDC. Few take-home points. Basic understanding of a lab test is the key to maximizing its use. Lab tests have many strengths and equal weaknesses. So we should be able to take the strengths more and also know the underlying weaknesses. Timing is everything. Right drug for right bug at right dose given at right time is the mantra. And WHO 5 moments of hand hygiene saves life. So when antibiotics stop working, when the helpless ICU consultants call you that please tell us which drug we can give, when all the drugs are resistant, so infection control is very important. So two very good sayings which I really like. To learn how to use antibiotics, one must first learn how not to use the antibiotics. And antibiotics kill bacteria, not our anxiety. So stop the just in case indications. Thank you. So these are my references. Thank you for patient listening. Thank you, Priti. It was really a wonderful presentation. We'll just ask if there's any questions. Actually, can you say, because you always talk about this antibiotic resistance, can you tell about antibiotic resistance also? A few lines about that. Yeah, basically antimicrobial resistance is when the drugs stop working in those cases. So basically we have this, whatever we have seen by now, the zones and the MIC detection. So that we do to detect whether the given antibiotic is actually sensitive, intermediate or resistant. So this AMR comes under this resistant category.
Actually, we have many technicians from small labs here. So, any advice which you would like to give us when sending samples for culture or ASTs?
The first and foremost thing I would say, it should be every sample should be dealt as if it is a patient. So when you consider a sample as a patient, then actually the outlook changes totally. So you will want to have the patient history. So from where the sample came. So you will search your own answers, like from where the site came. So whether whatever I'm isolating the pathogen, is it site specific or is it just a contaminant or a colonizer? So should I go ahead and put the AST or should I treat in those cases? So these things are very, very important. So consider your samples as your patients.
Thank you, Preeti. Any other questions?
And also quality check. So quality check is very important. Your internal quality controls, you should do them at least weekly basis. And if you have any doubt and it is deviating from your quality parameters, repeat it. So we have the APCC strains in microbiology. So it's always better to have those strains handy, at least the basic strains to compare with, because those are the standard strains. So you will come to know whether you are deviating from the standard.
I hope this topic was useful for all of us. If any of you have any other topic which we need to discuss in further sessions, please send us you can write it in the feedback form or you can send a message in our WhatsApp group.
Thank you, Dr. Takey. It was very nice.
Thank you, sir. Thank you so much.
If you start taking antibiotics, what happens to the results? If the patient has already taken antibiotics, then the entire report is not reliable.
We cannot say that. We can always de-escalate or escalate depending on whenever we are getting the report. We can de-escalate. If we are using some other antibiotic, we can de-escalate to the other antibiotic, which is actually given in your AST report, or escalate to a higher antibiotic if required. So that can be done.
The report can still be relied upon even if the patient has taken antibiotics. The report is still reliable.
Yeah, you can rely upon not 100% because it should be culture reports usually should be taken before starting any antibiotics or at least maximum before the after the first dose. That's what we say.
Okay.
But for few organisms, like I mentioned, enterobacter and all, so along the course of treatment, they gain resistant automatically. So in those cases, you anyways have to repeat the culture sensitivity testing, the escape pathogens and all. So while the course of treatment, they gain resistance actually.
Okay. And the last you mentioned some ratios. No, I didn't understand actually. You said we have to know
BMQ. Yeah, BMQ. So that is when you have like drug panels and you have two sensitive antibiotics. So which one to use? So that is, I go to that thing.
Yeah.
Yeah, this one. So, for example, in a patient, you have got E. coli in urine culture, and all other things are resistant, and only norfloxacin and nitrofurantoin is sensitive in your case. And you have obtained these two MIC values. So, how to decide which antibiotic will be best for the patient? So, for that, this BMQ will help. So this is a ratio susceptible breakpoints. Those are given by UCAS already. So susceptible breakpoint upon whatever MIC you have obtained in your report. If you divide that, you will get the BMQ value. So greater the BMQ value, the drug will be more useful in that patient.
Okay, thank you. So that will be given in the report itself or we have to calculate?
You can always contact the microbiologist because the breakpoints and all won't be given in the report. Few places they have started giving, but those are only the premier institutes where they give this values actually. But all other places it's not given. But you can always, based on case to case basis, you can contact the microbiologist.
Thank you.
I request all others to fill the feedback form. Thank you, Preeti. Thank you for such a wonderful presentation.
Thank you, Divya. Thank you for having me here.
I thank each one of you who have attended this session. Please fill the feedback form before you leave the session. I see some people raising their hands. If any question, you can ask. If no questions, we will end the session. I thank each one of you for attending this session. Once again, I thank you, Preeti.
Thank you, Devi. Thank you all for attending. Thank you.